Good afternoon, everyone. I want to appreciate COLDA for the opportunity to share insights on what we're doing in Delta State and implementation projects. So we're looking at the impacts of Project-StopHepB on strengthening PMTCT from 5 pilot facilities in the States. And just to say that my presentation will follow this outline, background, thematic areas of intervention, key outcomes so far, conclusions, recommendation, appreciation. Just to appreciate the HBV Foundation for funding this project. Project-StopHepB is a novel one in my state, Delta State, collaborating with the state's Ministry of Health. Just a little background that Delta State has, from the Ministry of Health, 8% prevalence of HBV. But what this project really intended to do was to get some insight about the prevalence of HBV among pregnant women, and also to strengthen providers' knowledge on HBV management, and also to establish some kind of strengths on linkage to antiviral TDF prophylaxis, and also to increase bed dose uptake, which is very big on that. So the thematic areas of these projects, because prior to this time, the data I'll be sharing, actually, and this project is ongoing, and data I'll be sharing will just be from February, when it was launched, to May. We identified last year some gaps, areas that needed to be strengthened in terms of training, screening, linkage to care, and hepatitis B bed dose, timely uptake. Just to share insights, this was the ANC attendance for the 5 pilot facilities across. So if you can see that pregnant women, they like to begin their ANC from especially second trimester, about 23.4% and all that. We found out that some social-cultural factors were responsible for that, and so that's it. Then the area of screening, we screened a total of 2,844 pregnant women, and we were seeing the prevalence at 1.86% so far. In terms of linkage to care, between February and May, we had 55 positive cases, and 4 have been linked to antiviral prophylaxis. In terms of the bed dose, what we did was to decentralize the bed dose, because last year when we did an assessment of timely bed dose uptake, we saw that the timely bed dose uptake was 5.8%, which we want to target based on WHO's targets as at least 90%. But what we did was to decentralize the bed dose and then install a cooling system in the labor ward and get the vaccine into the labor ward. And that's the reason why you are seeing the increase there. And we moved from 5.8 to at least 85.2% of bed doses were given within 3 hours, and including bed dose administered even on weekends, which was not the case. And so this was very impressive. But of note is that none of the newborns from across these 5 facilities were given, got the bed dose within after 24 hours. So which was very impressive for us. Just to say that this project is ongoing, we're still monitoring, and we're seeing that some of the strategies we're adopting can really be scaled up and to help us, especially improve on bed dose uptake for the newborns in our states. We're also recommending that these gains can be tweaked and also can be expanded. The HBV vaccine should also be decentralized, which is very important. That was the reason why we had the geometric increase from 5.8 to 100% within the facilities. And so this is very interesting for us. And these are my references, and I want to appreciate the HBV Foundation, the Hepatitis Advocacy Foundation, the Delta State Ministry of Health, the Humata Charity Foundation, and COLDA for this opportunity. Thank you very much.